Okay, thank you very much, Joanne, for your introduction. Welcome also on behalf of EAPC and the EAPC reference group on the public health approach to palliative care to this webinar, which is the second in a series of webinars organized by the reference group. My name is Agnes van Heide. I'm a professor of end-of-life and palliative care in Erasmus University in Rotterdam in the Netherlands. And I was asked to moderate this webinar for you. I think we have a very nice program for today. The theme of today's webinar is the evidence base for the public health approach to palliative care. And we have two very interesting presentations. Joanne, can you show the agenda for today? The first speaker is Steven Vanderstichelen from the End-of-Life Care Research Group at the Vrije Universiteit in Brussels and Ghent University in Belgium. And he is going to talk about the complexities and challenges in a public health palliative care research approach. And the second speaker is Joe Sawyer from University College in London, who is going to talk about the evidence for the effectiveness of a public health palliative care approach. After these two presentations, we will have time for discussion with a panel of experts. This panel includes our first speaker, Steven, but unfortunately Joe Sawyer is not able to be with us today, so his presentation is pre-recorded. But instead we have two very interesting other panelists, which include Professor Carol Tishelman from Karolinska Institute in Stockholm, Sweden, and Luc Deliens from the Brussels-Ghent research group. I will further introduce them to you after both presentations. I think that is for the introduction. Perhaps next slide, Joanne. As said, this webinar is organized by the EAPC reference group on public health and palliative care, which is a group that promotes the public health approach to palliative and end-of-life care by organizing and conducting different activities, among which organizing conferences, contributing to conferences, writing papers, setting the agenda, etc. And as said, also by organizing a series of webinars. I think we can now start with the first presentation by Steven. So Steven, if you are ready, please go ahead.
Thank you. I'll quickly share my slides and maybe ask Joanne in the chat or in the Q&A box. I noticed participants indicate that the chat is disabled. So thought I'd maybe first point that out. I'll quickly share my screen and hopefully. Okay, can you see the correct screen? All right. Thank you, Agnes. Thank you, Joanne. My name is Steven. I'm a postdoc researcher at the End-of-Life Care Research Group, and I'm the research coordinator of the Compassionate Communities Center of Expertise in Brussels. And I'm also part of the steering committee of the reference group on public health and palliative care. And my talk today is really based on the chapter that Luc Deliens and I wrote for the Oxford textbook on public health palliative care, in which we give a bit of an overview and introduction to what the public health approach to palliative care research is, what the appropriate methods and research streams are, and what the complexities and challenges are in conducting this type of research. So we'll start with what it actually is. And as a clinical practice, of course, palliative care is traditionally focused on the medical and nursing interactions between individual patients and their family carers and professional caregivers. And therefore, palliative care research has predominantly focused on clinical and health services research, and until recently has painted quite a medicalized picture of caregiving for the seriously ill or at the end of life. But the public health research approach to palliative care consists of two main aspects. Rather than a focus on clinical and health services, it's interested on the one hand in monitoring, and on the other hand in improvement. So first, monitoring population health and the structural, social, and environmental factors that influence it. And on the other hand, improving or promoting population health at the end of life and around serious illness through prevention, early intervention, and harm reduction. So that implies, well, it doesn't imply, it straight out says so, that the task of researchers in this endeavor is quite active, is quite involved. We're trying to change and improve things rather than only monitor or explore or describe. And the public health research approach to palliative care focuses on communities in many cases, social and economic determinants of health, the impact of policy changes on population health and well-being at the end of life. And additionally, the public health perspective on palliative care is focused on the full relevant population, rather than when it comes to clinical research and health services research, it's often focused on certain patient populations identified based on either service use or biopsychosocial risks. But whereas public health research is focused on the full relevant population. Now, what does that mean? Who is the full relevant population? Well, it's you and me. It's basically all of us, because it's everyone who will ever die or come into contact or be confronted with serious illness, family caregiving, or the end of life. The only variance is basically frequency and timing. So that's a big difference. But within public health research in palliative care, there's two broad approaches that are generally acknowledged. There's the traditional public health research approaches, and then there are the new public health research approaches. And as you'll see, I've put those two terms in quotation marks because I don't really like the terms. I feel like traditional implies a certain conservativeness or outdatedness or irrelevance, while that's quite obviously not the case. This is a very important research approach. They're just a little bit more well established. And new kind of implies that it is newer than it actually is. But it is true that these new public health research approaches, and we will see what they are in a moment, are rapidly gaining in popularity in the last few decades. So traditional public health research approaches often start from a post-positivist epistemology, which maintains that the ontology that a reality exists. So they're characterized by post-positivist views. Contrary to positivists, post-positivists believe that they can that reality, while there is an objective reality or objective truth, it can only be known indirectly, because human knowledge is based on conjectures, and so further investigation or further research can always lead us to modify what we know about reality. And these types of approaches are predominantly quantitative epidemiological studies. And they are concerned more often with monitoring and assessing circumstances, social challenges, planning services, and policies around serious illness, death, dying, and loss. And topics often include quality of care, quality of death and dying, end-of-life care decisions, care setting transfers, place of death, prescription and deprescription practices, healthcare costs at the end of life, service use, and so forth. Now, new public health research approaches depart from a social constructionist epistemology, and social constructionism proposes rather that certain ideas about reality arise from collaborative consensus rather than pure observation of reality. Moreover, many proponents actually believe there is no such thing as objective reality. Rather, individuals and groups help create reality, and truth is therefore constructed and maintained in social interaction. So quite a different approach from that standpoint. These approaches developed largely from the community engagement movement and emerged in part in response to a growing criticism of the traditional public health approach to palliative care. And that criticism holds that the traditional approaches tend to reinforce the dominance of healthcare professional perspectives, so that this traditional focus on professional responses also serves to disempower communities and thereby placing further demand on health services going forward. Often you'll find in these types of approaches that participatory action methodologies are prevalent, and they put a large emphasis on the pursuit of equity, access. They pay a lot of attention to the role of social and environmental factors in population health outcomes. And topics often include social relationships and networks, community engagement, volunteering, environmental and social determinants of health and well-being, support networks in end-of-life care, the role of public institutions in health promoting palliative care, and death education, and so forth. And so it's important. I spent a bit of time talking about the epistemology behind these approaches because the choice of research design in public health palliative care research, as in any research, tells us something. It reveals certain fundamental assumptions that we have regarding the nature of reality and to what extent we can obtain knowledge of it. And research designs can generally be classified based on these things, but classifications of research designs and methodology are really endless because they can be categorized not only based on ontology and epistemology, but also what kind of data that we're interested in, what study population specifically we want to learn about, what data collection methods we want to use. However, I do find that a particularly helpful way of considering research designs for public health palliative care is by dividing them into the following three groups, being observational research designs, experimental research designs, and change-oriented research design. Now, this classification is the one I prefer, and it is by no means perfect. It is by no means exhaustive or mutually exclusive, but I find it helpful. Also for me, because it kind of represents a continuum between sort of the traditional approaches towards the new public health approaches, as we'll see. And if we start with observational research designs, we have the staples of being a lot of quantitative research designs, such as cross-sectional studies, are a really important tool. It's probably one of the research designs that most people are familiar with, and it provides kind of a snapshot in time of a certain population for a certain outcome, such as, for example, disease prevalence. And they're really good to in giving us a broad overview of what the state or the situation is at the moment for a given population. What they're not good at is establishing causal links or causal inference. So we can't causally link our exposure to outcomes that we're interested in. We can only provide associations at best. You can, of course, do multiple repeated cross-sectional studies and turn into a longitudinal design. But in general, this is causal inference is not usually something you seek after with cross-sectional studies. One of the examples of such a study is, for example, this one by Vanderstichelen and colleagues. We're looking at, for example, the indicator of receiving appropriate end-of-life care for people who died from cancer in Belgium. They looked at these indicators being, for example, opioid use, home death, number of contacts with family physicians, multidisciplinary oncology consults, and they looked at that cross-sectionally across this entire population for several moments before the moment of death, and seeing how the use of these indicators increased or decreased. Another really good example is, and a very influential one, I think, is the paper by Sleeman et al., published in 2019 in the Lancet Global Health. And they used a huge set of cross-sectional data and performed analysis on it to make projections for the future. And so they found, for example, that 48 million people are going to die annually by 2060 with serious health-related suffering, which is an increase of 87% since 2016, which is huge. So while often touted as basic research design, cross-sectional studies are hugely helpful for public health palliative care studies. Another well-known quantitative research, observational research design is cohort studies. Cohort studies start from the exposures, so they divide their population into groups based on exposure to a certain risk or protective factor, and then they follow these cohorts up in time, and then examine the outcomes in question at the end. And cohort studies have been used to, for example, in this paper by Julian Abel and colleagues, to study the connection between compassion community initiatives and unplanned emergency admissions and admission costs. And in this case, for example, found that this compassion community initiative was shown to decrease unplanned emergency admissions. So really helpful and provides really good evidence. Another one is case control studies, where case control studies do it a bit opposite. They don't start with exposure, they start with outcomes and divide their groups, their population into groups based on outcomes. So you have your case group, and then usually your control group who do not present the outcome. And then you look backwards, looking at the exposure within both of these groups to draw conclusions. One example of such a study is a study by Matens and colleagues, who in this study they looked at people who received palliative home care support, and they matched those people with those who did not, based on individual estimation of their propensity for receiving palliative home care support. And they used administrative data for this. They used a one-to-one case control propensity score matching algorithm and found that the use of palliative home care support positively impacted quality of care and reduced total cost of care at the end of life. So these are some of the quantitative staple research design in observational research. There's also qualitative ones. There's document analysis that you could do, interview studies, and ethnographic approaches. When we think of document analysis, you could think, for example, about analyzing the contents of policy documents or analyzing the narratives or discourses, the media contents. But one of the maybe most self-evident, almost too self-evident to mention designs or methods that that fall under this that are hugely important are the literature reviews. So systematic reviews, rapid reviews, scoping reviews alike are an enormously important tool for researchers in public health palliative care, and as it is in many sciences, to provide an overview of the state of the art and find points to move forward, to move the field forward. These are some examples of colleagues of ours who have done systematic reviews of compassionate community initiatives and civic engagement initiatives in serious illness, death, and loss. Another type of that I count under document analysis approaches that I feel like we don't see enough in the field is doesn't look at literature, or it does, but what it does is looking at all the evidence found and directly compare them through a meta-analysis. Now, meta-analyses are a very powerful tool to get at the state of the art, not just of the literature and the discussion, but also comparing directly effect sizes of different studies. And this one's a very influential study by Holt-Lundstad. I think many people know it. It looked at social relationships and mortality risks. And it found, for instance, that social relationships, and especially complex measures of social integration, had the highest protective effect, or were most protective of mortality risk for several conditions associated with mortality. Now, I think in our field, we need to do next is look at the connection between social relationships and complex measures of it, and health and well-being at the end of life. That would also be really important to study further. When it comes to interview studies, this is I really like this study by Max Kleibach and colleagues, where they did interviews with participants in community-based intergenerational arts initiatives about death and loss, where they brought children and older adults together to talk about death and the end of life and loss. And used interviews to explore the power dynamics in these types of initiatives. And the article highlights the power that adults in between, as the authors call it, had over, and the responsibility that they felt for the children and the older adults participating in these workshops, which added an entire new layer of complexity to them and to organizing them. Finally, ethnography is a type of field research originating from cultural anthropology, which examines the behaviors of participants who represent a certain in-group in natural setting and is interested in understanding their interpretation of their behavior. And so to this end, it often uses participant or non-participant observational methods of data collection. And while not as prevalent as other research designs in our field, ethnography can be a really appropriate design to track and identify the processes and relationships through which events, practices, and things become meaningful, and how behavior manifests itself in certain contexts. So, for example, the manifestation of existential suffering at the end of life, as in this study by Rens and colleagues. Now, the second category in my classifications, so to speak, is experimental research designs. And these are focused on the manipulation of an environment to test hypotheses and then to establish, if possible, causal links between predictors and outcomes in a given setting. So now we've reached the collection of research designs interested in causality. And there's many types of experiments possible with various levels of control, randomization, complexity. You have the most well-known and often taught it as the gold standard for evidence, it's randomized controlled trials, and you have also non-randomized controlled trials, waitlist trials, and so forth. And they're really popular, again, in clinical research. But in public health palliative care studies, manipulating independent variables may become really impractical and unethical, excuse me, when it comes to involving human subjects and when you switch out a laboratory setting for natural environments such as communities. So they're definitely useful, but they're rare in public health palliative care research. They also represent a static and linear approach to stimulus or intervention and outcome. And they really assume that it is possible to optimize, or even desirable to optimize an intervention prior to implementation. And we'll see later that that often does not really apply to public health palliative care research, and especially when it comes to more change-oriented research. But it has been used in our field, and so it is useful. For example, randomized controlled trials have been used to evaluate health system outcomes of social and practical support interventions for people with life-limiting conditions. This is the paper on the left, the protocol on the left by McLaughlin and colleagues. Non-randomized control trials have been used to evaluate, here on the left, the impact of care networks on health outcomes, including quality of care, caregiver burden, place of death, and resource use. So they have their place, but you'll more rarely see them in our field. And brings us to the third group in my classification, the change-oriented designs. And in change-oriented research designs, the boundaries between researcher, research population, and setting, and between intervention and context are often blurry, sometimes considered non-existent or not meaningful. Researchers themselves often partner with the setting and then become part of the intervention, and vice versa. The setting also becomes part of the intervention and the research. Often you'll see participatory action research designs here, particularly in the new public health stream of palliative care research, which works on the principle of co-creation. And participatory methods are particularly useful to bring in perspectives of those affected by the intervention in which they're involved, and to also evaluate conceptual outcomes of interventions. So in participatory action research, those directly affected by the interventions, they're not only involved, or ideally not only involved in evaluating it, but also in the design, development, and implementation processes. Now, this is, of course, easier done than said. We know this in the field in reality, that this the extent to which those affected are involved varies greatly. And the design has been used to engage difficult to reach or indigenous communities with limited access to medical service to develop palliative care programs. And the image to the left, bottom left, it's not entirely visible, is from one such study by Kelly and colleagues. But it's also been used to examine advanced care planning peer education through volunteer perspectives on training and community engagement activities, or to explore power dynamics in creating spaces for community engagement in end-of-life issues through intergenerational arts initiatives. So that might ring a bell. That's, I go back a little bit, that's also this paper, so you'll see immediately the limits of my classification system. While it showed up here as an interview study and an observational design, it also shows up in my third category because it is a change-oriented project. But I thought it was still worth mentioning. And so participatory action research is particularly popular in the compassionate communities literature and movement, where strong and close collaborations with local communities are really core principles. This is a model called the Circles of Care model by Julian Abel and colleagues on the left. And I think it's also an influential model and important because it represents, or it gives a visual representation of the social ecology of patients and their networks. And on the right side is an application of that Circles of Care model in the study I mentioned earlier by Kelly et al., where they developed palliative care programs in indigenous communities in Canada. This model, I don't think it's been published yet, but Joachim can correct me if I'm wrong. But this is designed by Joachim Cohen, my colleague, and when I first saw this model, I didn't actually like it because it seems so chaotic. But the more time I've spent with it, the more I've grown fond of it. I think it's a really useful tool for compassionate city development and to help your stakeholders and researchers think about the principles you're implementing, think about which target groups you can, it's obviously not exhaustive, but which target groups you can involve and which activities can target them and what the primary focus of those activities then are. And it does this for each of the key principles underlying a compassionate city development model, being participation, collaboration, empowerment, coordination, sustainability. Now, what is also really helpful about this model, I find, is it challenges evaluators to link their indicators to the implementation aspects. So linking your outcomes to your primary focus, linking your outputs to the activities or the actions that you're actually doing. When you're describing inputs, linking those to the target groups you're involving and who have a active role to play, and to map your success factors on your key principles. I also like these models in these research designs. That on the left is the New Essentials, Palliative Care New Essentials model that I've borrowed from Palliative. I forgot to put credit on this slide. I'm sorry. The one on the right is a model that I've borrowed from the Transform platform for community integrated care, or integrated community care. And I like that one a lot because it highlights one of the functions of compassionate communities, is linking up healthcare with communities. But it also acknowledges that healthcare is an aspect or a part of the whole, and it gives equal or more weight to community aspects such as friends, workplaces, schools, neighbors, faith communities, book clubs, and so on. they all have a role to play within a compassionate community, providing support and care for people with palliative care needs. I also wanted to mention this study. While it itself is not necessarily a change-oriented design, it did lay the foundation for what I think is a really important tool, an instrument and concept in change-oriented research, which is death literacy. This study by Horsfall and colleagues showed that informal engagement in end-of-life care and support led to network growth and increased network density. And it laid, as I said, the foundation for death literacy, which, similar to health literacy, is a tool that's theorized to be, it's still in its infancy, but it's theorized to capture knowledge and skills related to end-of-life care support. And it's theorized to provide positive or better outcomes at the end of life, such as quality of life, but also self-efficacy in providing care for others, and so forth. And the tool to measure it has been suggested to be useful for comparing public health palliative care initiatives across settings based on a similar impact or envisioned impact of building community and individual capacity for end-of-life care and support. So we've talked overlooking these big groups of research designs, we've kind of seen a gradient in complexity increasing, especially when we hit experimental research designs, where lots of different parts in your experiment have to be optimized and interact with each other, and you have to account for all of that. To change-oriented designs, where the experiment, so to speak, or the intervention is part of the setting, and becomes really hard to keep these. It becomes impossible, really, to keep these distinct from each other. And it requires us to kind of think about what is complexity then, really. How do we understand complexity? And several definitions of it exist, but most indicate that it's an emergent attribute of a system or an intervention caused by the interaction of multiple parts, the variability in the interaction, and the unpredictability in the outcomes of that interaction. But more than a function of interacting between discrete elements, even, others argue that it's the complexity should be seen as a dynamic and constantly emerging set of processes and objects that not only interact with each other, also with the systems that they become embedded in, but they become defined by those interactions. They become products of those interactions. You get these feedback loops. And complex interventions, such as compassionate communities or cities, cannot really be described by linear pathways for that reason. Linear pathways meaning between an intervention and its outcome, but they're marked by non-linear pathways, multiple confounding factors, and these feedback loops that I've mentioned. Because in many cases in public health palliative care research, there is no real equivalent of the sterile laboratory that in clinical research or in biochemistry is the case. Research and participants take on dual roles, as mentioned, and interventions become these products that change during implementation and evaluation. It's not desirable in any way to optimize your intervention prior to implementation, because the context is part of the intervention. The goal is to create a change in all of these systems, and often that means that the intervention will change with it, and that you get these unexpected, spontaneous, emergent outcomes. So it's really important to choose the appropriate methods or combination of methods or the toolbox you want to work with to deal with this complexity that these types of these experimental or change-oriented research designs pose, or interventions pose. Complexity can also result from conceptual issues. So how do we measure the core concepts in our field? How do we know we're talking about the same thing? And we find ourselves confronted with the same kind of challenge that the Healthy Cities movement of the WHO were grappling with during their evaluation phase. And these are some of the more core concepts that we see in a lot of the literature and in the movement. And when I hear people talk about these concepts like health and the impact, well-being, capacity, I'll speak for myself, but I'll find myself nodding along, but then also realizing, wait, do I really know what they're talking about? Do we understand the same thing when we talk about capacity or to talk about health? And how do they, because one operationalization of one concept that's so vital to this field can vary widely between studies. So it becomes very difficult sometimes to compare results. Health, for example, and I think this will be familiar to many of you, but I still think it's the case or an important point worth making. How do we define health, really? Is it a function of physical or mental functionality or ability? And that sounds reasonable until you realize that older people are unable to be healthy according to definition. So that's problematic. So then there's, is health absence of illness then, which initially also sounds reasonable, but then you're defining health based on your definition of illness. And we know that due to our expanding knowledge of medical and clinical and knowledge and scientific knowledge and our shifting paradigms, that is also problematic. If we think back, not too long ago, for example, homosexuality was considered an illness or a disease. So that's also a problematic way of treating it. I think we need a more multidimensional approach to health. And then we are left by defining health and a lot of these concepts by proxy indicators. Certain concepts like this cannot unilaterally or in one specific way be measured. So it's important in our research that we're really clear about what aspect of health we are measuring or we are trying to influence, what that says about more overarching dimensions of health, and how we can compare those across setting or across interventions. So, for example, proxies could be disease prevalence in a given population, or mortality statistics, or healthy behaviors or lifestyles, and so forth. And impact is another one. How do we? This is really the buzzword, I think, but we often don't define what we mean by impact, and it's more something that like hangs in the air. We all want to create impact, but how do we capture it and how do we compare it? Public health palliative care intervention studies often require really long timeframes to develop, implement, evaluate, and it can take a very long time before an effect can be observed or registered. And in many cases, the impacts that we envision or that we hope to achieve are also beyond what we can call the ceiling of accountability, as the term borrowed from the theory of change literature. But these are impacts that we don't have full control over. There's many other factors that impact or that influence these envisioned impacts, and that may create a lot of noise where our effect may not necessarily be quantifiably measurable. So we need to think about other ways of measuring impact. And often we don't know what the impact is going to be. We may have one impact envisioned, but there may be many more outcomes that were unforeseen. Any change you make in a system, especially in nested systems, will have ripple effects. There's actually a method called ripple effect mapping that I know some colleagues here today have used. And sometimes it can be the task can be to follow where those ripples lead and not to pin ourselves down with certain outcomes or impacts that we've predefined. Also practically, often a sustainable or structural change is sought after in an intervention, which may take much longer than any funding agency is prepared to or even capable of supporting. Which is also something to take into account. Complexity can also result from scale. Conducting studies in real-life context confronts us with dynamic environments, for example, recognizing different perspectives, unanticipated outcomes, evaluating processes underlying these transitions, like opening up the black box behind the outcomes that we find or that we envision, adapting the intervention over time. In the same way that interventions may be complex in the way that they have numerous components that interact with multiple unpredictable ways, so too are the systems in which they're implemented, right? So the introduction of even simple interventions, for example, changing a law affecting the price of products that affect health, may cause cascading, emergent, unpredictable consequences in every interlinked system that law touches. So we kind of have to accept that we won't always have full control over the situation, and maybe that will also help us open our eyes to following the impact rather than trying to a priori pin it down. This I've mentioned. There's a few challenges that I see for the field when it comes to grappling with this complexity, and I also look forward to hearing what Joe has to say about this when it comes to evidence. But the one maybe the development and the validation of tools and instruments that allow for cross-setting comparisons. I think that, or rather, the main challenge would be not to be deterred by this challenge, because while it may be difficult and attempts are never going to be foolproof or perfect, they will very much be flawed, comparative analysis are still really worthwhile doing, and we need them. And I think we should start looking at it in the sense that not try and deliver a perfect product, a perfect approach that is beyond reproach, where reviewer 2 will have nothing to say, but we should look at it as contributing pebbles to an ever-growing mountain of evidence, and so that will help us see more clearly in the future. I think all research is flawed. I think it's about being transparent about it and recognizing the limitations, but still making an effort in doing so. And then secondly, to employ methods and frameworks that help us capture processes, not just outcomes, and also emergent outcomes, not just the ones defined ahead of time. And methods that allow for narrative or quantitative comparison across studies. I've previously mentioned the importance of meta-analyses. But when it comes to these frameworks, I think we really need to look toward complexity science, implementation science. There's a vast literature on this. The problem with that as well is that there's a huge repository of existing frameworks, half of which have not been used or have not been reported on. And one can really easily lose their way, especially if you're not familiar with it. And so we really need to do more efforts in drafting up guidance. And one of my colleagues has taken a first step in doing this. And I'm not just bringing this up because my name's also on the paper, but this is a really interesting piece of work. I really commend Hanna for doing this. She helps readers identify theoretical frameworks that can be used to evaluate processes behind public health palliative care initiatives, and also gives some guidance on why these frameworks and to what end each of these frameworks can be used or combined in a meaningful way. And then finally, because I'm outstaying my welcome, finally, I wanted to add that participatory is not a dirty word, and it is not the antithesis of rigor. I think we need to, especially in public health palliative care research, especially in the more change-oriented and new public health palliative care research approaches, we need to step away from this, from the gold standard that's often touted from medical and clinical research, as there's the randomized control trial, because I think we'll find in many cases that it is not a relevant method. And I might ruffle some feathers here, I don't know, but it is not a relevant or appropriate method in many cases, simply because it requires things to be optimized to a context where the entire point is that the context is part of the context is what we're trying to change. The context is part of the intervention. So I think we need to look more towards participatory methods, be transparent in how or what roles we take in the research, but also acknowledge that is do more justice to the method is, I think, what I want to say, because it is a very valuable method with its own shortcomings, but we shouldn't use it to try to do things that it doesn't do. We should also not try to use methods that do things that are not appropriate for the field, if that still makes sense. But with that, I want to thank you for listening and leave it at that.
Thank you, Stephen, for this interesting and thought-provoking overview of research methodology in the public health approach towards palliative care. I think, well, you addressed many important and interesting topics, and as any good scientific presentation, you perhaps raised more questions than you answered, but that's, I think, only to be applauded. So thank you very much. Before addressing comments and questions regarding your presentations, we go to the second presentation of today that is provided by Joseph Sawyer. And as I said at the start, Joseph is not able to be with us today. So his presentation was pre-recorded. And I would like to ask Joanne to start this pre-recording, and Joseph will introduce himself in his presentation, so it can be started now.
Hello, my name is Joseph Sawyer. I'm an academic clinical fellow in palliative care based in the UK. And what that means is I'm a palliative care doctor, but I'm also just coming to the end of a 3-year PhD, which has been researching the role of compassionate communities for people affected by dementia. So the aim of my talk today is to set something of a challenge to the world of academia, inclusive of policymakers and service evaluators, to perhaps think differently about evidence, to consider what complexity, tension, or paradox might mean, and how it might relate to the concept of effectiveness. So I don't plan on listing and critiquing all of the evidence. I've done this more thoroughly in these two references here. One is an academic paper, which is open access, and another is a book chapter from the Oxford textbook of public health palliative care. Instead, what I'm aiming to do today is provide you with a conceptual overview of the challenges in evidencing this body of work, addressing what I see as some of the tensions before outlining some orientating principles that might allow us to move forwards. So central to this is a fundamental question, and it's one that I've returned to many times now throughout my clinical work and my research. And that is, can our own progress-orientated ideals and the desire to evidence them perhaps dismiss what is important to know and understand in the first place? Now, I'm going to try and address this question throughout, but the answer I will leave for you to mull over in your own personal practice. So I've been studying public health palliative care for around about 5 years now, and I believe that the underlying theoretical constructs and the philosophy provide a unique way of looking at end-of-life care, foregrounding relationships as a vehicle for understanding meaning and value, which can then act as a powerful motivating force for the improvement of care. However, communities, be that people, places that make them, or the relationships they're built on, are complex entities. Much of what they are is intangible, hidden from the empirical world, but no less powerful in their effects. This poses problems when thinking about evaluation or effectiveness in the traditional scientific sense. Particularly in Western culture, we have become accustomed to a scientific paradigm that might prove effectiveness and point in a direction towards progress. The science of evaluation has reinforced this to an extent, allowing us to pursue an ideal into a reality in such a way that success is separated out from failure, and a pathway to progress might become apparent. This is achieved through a carefully constructed positive feedback loop. So here our ideals are brought into practice through the constructed moral and ethical structures that might be seen to drive unquestionable support for an intervention, which is then evaluated to successfully demonstrate the virtues of the initial ideal. This pathway is representative of how science has succeeded in bringing certainty and control through knowledge and evaluation, and how that's then allowed us to overcome complexity and drive progress. It is also somewhat of a closed loop, and it does not perhaps allow us to think what progress means in the context of end of life. Progress where there's no forward direction can be a disorientating concept on which to found the principles of evaluation and knowledge gain. Asking the question of what constitutes success in the context of public health palliative care can bring up some challenging issues. When we speak of public health palliative care, there's often talk of paradigm shifts, of improving access, equity, and justice. And yet, as I've just mentioned, the overarching direction of travel can become murky when we're placed at the borderlands between living and dying. At the end of life, the labour and love put into all that's been so intricately grown will ultimately unravel. And this can create a deep-seated sense of pain and suffering as we mourn what's lost. Yet when a life unravels, it also creates its own unique geography, filled with new experiences, relationships, and moments of profound intimacy and meaning. It's within the solitude of this unraveling, in amongst the sadness and the suffering, that we might be paradoxically greeted by moments of value, moments of transformative effect. At this point, delineating what progress and evidence of effect actually means can be quite a disorientating process. Separating out success from failure, sorrow from joy, beauty from all that's broken and soiled, can deny what's important to know and understand about death, dying, and loss in the first instance. The true beauty of the ideal is perhaps not its connotations with success and progress, but a hospitality towards all that is imperfect. In the words of John O'Donoghue, the true beauty of an ideal is its hospitality towards woundedness, weakness, failure, and fallback. And it's here, through relationships shaped and molded through acts of caregiving and receiving, that we might accommodate value or the gifts that are of transformative effect. There are many practice examples of this littered throughout the literature and throughout people's personal stories and experiences. For example, if we construct an ideal of what care looks like at the end of life, we might think of someone being at peace. Or perhaps a more tangible example would be the absence maybe of pressure sores. Yet at the same time, the presence of suffering and struggle, or the emergence of a pressure sore, can sometimes be intimately and inseparably linked from acts of compassion. It remains to be so that it's through the inseparability of these processes, the fusion between the light and the dark, that we ultimately come to heal. The commonality, the uniting principle of acts of genuine care, is a hospitality towards our own human vulnerabilities and a realization of the gifts that this might impart. For me, this is a foundational principle of public health palliative care, and a point on which evidence of effectiveness needs to be orientated if we're to make progress and to demonstrate effect. In this model, the effects and outcomes are not always predictable, or indeed visible in the places that we're used to looking. We instead have to think about things differently, pay greater attention to context and culture, and have an open mind when it comes to what the outcomes of interest might be. At the same time, they may not show themselves according to the timescales a science of evaluation might impose on them. Sometimes a change may take years, generations to manifest in the first place. In this way, there's ample opportunity for the clamour or desire to provide evidence of effect, dismissing what's important to know and understand in the first place. There becomes a risk that an intervention is evaluated too soon, dismissed as ineffective when the locus of what might be of value has not been properly thought through or uncovered. Having reviewed most of the scientific evidence as part of my PhD, what I've tried to do in some of the papers I referenced at the beginning is categorize the evidence into two main sections. And the first relates to a community's capacity to act as an independent agent of care. The second is all about how a community does this. Here, the evidence is all within process and techniques used in developing a community's capacity to care, trusting in what this might achieve, rather than looking further down the chain at points of outcome, specific points of outcome. I've written about social capital, community engagement, empowerment, responsibility, and the factors that motivate and drive us to make a difference. There is a lot of positive evidence, but it's not uniform. And for me, this is okay, and it makes sense. It just reflects the complexity and also the inherent values within complexity, rather than just overcoming it. So much of the literature refers to this concept of a community as an active, independent agent of care, right? And this is opposed to it being a passive kind of recipient of education and other such interventions that might be kind of bestowed upon them. The link between communities and their function as agents of care is strengthened when death is conceptualized as a shared social process that encompasses the whole spectrum, so the processes of grief, caregiving, and bereavement. By rejecting the sub-specialization of palliative care into kind of component parts, there's recognition that there is value in understanding the totality of the experience, and this is an important theoretical contribution to the evidence of effect. However, it sometimes feels that theory is or can be misunderstood as hypothesis, and particularly when viewed through kind of the hierarchy of evidence that's now so entrenched. Theory can sometimes be dismissed or put on a lower kind of scale compared to empirical data or meta-analyses, which are thought to provide evidence of best effect. For me, theory evolves and is refined in response to experience and data, consistently developed, and robust iterations of theory are therefore a powerful form of evidence. Indeed, a lot of the evidence for public health palliative care and its effects reside in theoretical constructs, and these are integrated into practice as where knowledge progresses and we might begin to better understand the outcomes many people are striving for. The theoretical constructs originally put forward by the closer affiliation between public health and palliative care have resulted in an increasingly refined approach that is translated into community development projects across the globe now. There are many, many examples where people's experiences have been carefully examined using mixed methods research. When viewed in relation to carefully constructed theory that embraces complexity and nuance, this provides what I would consider to be robust evidence that communities can and do act as independent agents of care. So if communities and the relationships that make them have capacity to find meaning and value, allowing us to experience death and the suffering this brings in such a way that understands these moments of value and affords us the potential perhaps to heal into the emptiness death brings. How is it that this occurs? Well, firstly, social networks and social capital. The concept of social capital has been adapted to help demonstrate outcomes of interest. Yet there has been criticism that it's been used in perhaps an oversimplified way to demonstrate uniformly positive outcomes at the expense of a broader complexity. For example, the case of bonded social capital, so that's direct relationships that exist between people of similar backgrounds, close family or an inner circle of care perhaps. And whilst these can create close-knit communities and the virtues this brings, such as a significant body of resource, these ties can also potentially restrict individual freedoms and also bar outsiders from access. What the existing evidence has done in relation to public health palliative care has helped to demonstrate that social capital can be developed through end-of-life caring, and that this can lead to new experiences, some of which are of profound meaning and value, and have the potential to build community capacity and also a literacy in the processes of death, dying and loss. There's more work to be done in understanding the quality of these relationships and experiences, understanding that not all relationships are cohesive and functional, and how this might then translate into the ideals and objectives of public health palliative care. The second point is community engagement, development and empowerment. So if communities are independent agents, they're to be engaged with in such a way that encourages growth of what's already strong through co-production, rather than perhaps bestowing what might be perceived as being needed to strengthen what is weak. The way that social capital is harnessed depends very much on how community engagement is understood at this spectrum between informing and empowering. Much of the evidence here can be found from community projects, practice examples such as the one in Kerala that's been running since the 1990s. Beyond this, there are now many examples, practice examples from across the globe of compassionate communities and how they focus on community development by the creation and mobilization of support networks that harness some of the principles of social capital. Much of the evidence demonstrates valuable progress, the formation of the Deaf Literacy Index, and moves towards more system-level thinking. Is helping to provide a new framework for evaluation that integrates complexity as a point of value in and of itself, rather than something just to overcome. However, as knowledge progresses, which it inevitably will, new tensions are also coming to light. Issues around the intersection between public, professional and lay services and their implications on responsibility and the moral landscape are yet to be fully addressed. How, for example, responsibility, duty and motivation are operationalized by public health palliative care is yet to be fully considered, with the theoretical and practical details of this as yet perhaps poorly defined and acknowledged. So, to try and summarize, I've tried to provide a framework as to how we might understand public health palliative care through the lens of scientific evaluation. For me, personally, this body of work holds enormous potential, yet progressive change is not simply to be assumed. This is especially true if we follow a traditional science of evaluation that understands complexity, tension and paradox as something to be overcome, as opposed to something that has intrinsic value in and of itself. I've described some of the tensions the pursuit of evidence of effectiveness might present us with, and argued for an approach that considers perhaps how value is best understood. Ultimately, I believe this poses a significant question to all those involved in practice and research methods. Do we conform to a model that's closely affiliated with evidence of best practice, pursuing progress-orientated ideals into reality? Or do we focus on hospitality towards woundedness, weakness, failure and fallback, recognizing that this is perhaps the beauty of the true ideal? Here, compassionate communities might act as a lens through which we can build such a hospitality through trust and the relationships that provide a vehicle for this. In the latter, we build community along with all of its flaws and fallbacks in real terms and in real time. Thank you for your time and attention. I hope this raised some important points for you, which you can reflect on in your own practice and research. I'd be very happy to continue the discussion over email. Please do feel free to reach out. I've put my email address at the bottom there, and I look forward to hearing from anybody with interest. Take care. Thank you.
Thank you very much, Joe, although you're not here in real life. And in addition to giving rise to discussion and reflection in your own clinical or research practice, I hope it will give some food for thought for our discussion now. I think these were two very complementary presentations. So you could wonder how they relate to each other, how they fit with each other or do not fit with each other, but perhaps we can discuss a little bit about that. For the panel, I would now like to introduce again Dr. Steven Vanderstichelen. You know him in the meantime because he gave the first presentation. And in addition to what you already know about him, I would like to mention that he is the coordinator of the Compassionate Communities Expertise Center in Belgium, and that he is a member of the steering committee of the reference group, EAPC reference group. Second panel member is Professor Carol Tishelman. Carol is, in addition to being partly retired, has several positions. still several positions, among which a position as a chair of a research group at the Karolinska Institute in Stockholm in Sweden. And we have Professor Luc Deliens, who is the co-chair of the EAPC reference group, the soon-to-be president of the Public Health Palliative Care International group, and chair of the End-of-Life Care Research Group in Brussels and Ghent University in Belgium. And perhaps to start the discussion, either of you could give a short reflection or comment upon what you have heard in the previous hour. Carol, would you like to start?
Yes, thank you. And thank you, Stephen and Joseph, wherever you are, for your presentations. I was just thinking about an alternative way of categorizing, Stephen, the three types of research designs you were talking about. And I think it's kind of the elephant in the room in what both you and Joseph were talking about. And that's control and curiosity. And I think that you could just as well have the change-oriented research approaches at one extreme, followed by the observational and then the experimental designs. And then it's along a continuum of researcher control, or maybe curiosity also. And I think that while neither you nor Joseph mentioned these terms, I think that this is a lot of what we're talking about in terms of evaluation. And Joseph's very implicit criticism of different forms of science for lacking curiosity and being driven by their own goals. And you trying to sort of balance these, I think, more discussing it more in terms of which does what. There was also at some point, I'm not sure if you used the word or if Joseph used the word, but something about trying to capture things. And I think maybe that's the type of word that we have to move from, because research is never going to be capturing anything. It's going to be investigating portions of it at the expense of other portions and understanding some things at the expense of other things. And I think maybe we have to consider our vocabulary in terms of what we think we're able to do as researchers. And the other risk that I kept thinking about as I was listening to both of your presentations is the risk of over-medicalizing people's lives and society, and how to balance good and stringent and robust research of different types in over-medicalization, and a belief that we as researchers, clinicians, can just capture things more fully than I think that we're able to do. Some sense of humility. So.
Thank you, Carol. And before giving Stephen the floor to address some of the comments and questions of Carol, I would like to ask Luc if he has some general reflections on the previous presentations.
Yes, thank you, Agnes, and thank you, Stephen and Joseph, for your presentation. As Agnes mentioned already, they are very complementary presentations, but they were also very complex presentations. So there's a lot of information. So junior researchers might be very overwhelmed by these presentations. So I would just want to say to all those researchers, don't be too overwhelmed. It's an overview of the complexity of this domain of research. And so I think one of the most important things to realize is that when I started doing research, and I'm a sociologist as a background, and that's maybe interesting to just notice from the presentation of Joe, because he's a clinician, but actually his analysis is very social science driven. While I think Stephen's presentation is still much more influenced by the traditional research that we do in end-of-life care research. And so that's kind of interesting because Stephen is a sociologist and Joe is a medical doctor. And actually, Joe is more using what he calls evidence, but what we are very much biased. I'm saying we, meaning the research community in palliative care. And the evidence that we know is driven by the traditional research designs. It's driven by a hypothesis, or it's driven by a research question in a controlled research design. And when Joe is speaking about evidence, and that's, I think, very interesting, he's speaking about evidence from the social sciences. And that is a completely a different sort of evidence, because it's it's based per definition on a completely uncontrolled environment, which is a society. And so you can analyze all kinds of events in a society and come out with all kinds of nice results from your research. But most importantly, it's actually well, and that's, I'm coming back to what Stephen is saying, it's the monitoring of the society. So it's very important, whatever we do in palliative care, public health palliative care, I think observing what is happening in society is really the crucial part of our research, because that will show what is reality, and that will show also when there is undesired consequences of interventions. Because I'm a bit afraid about the whole development of public health palliative care research. So we are trying to develop the whole framework of the research for it. But I think we should learn the lessons from sociology, looking at what kind of lessons sociology overall has learned from developings in society. And very often it's like warning for undesired and unpredicted consequences of interventions. So observation in a society is very crucial. So maybe down to earth more, I like the concept that Joe presented, and it literally said the intrinsic value of complexity. I think that is a statement which I noted down immediately because I found that very interesting. And I was immediately trying to translate it to my own experiences. My research group in Brussels and Ghent is a community. And when I was starting up that research, I was all by myself with one researcher, and then it gradually grew. And at the beginning, I was very, very eager to control all the processes in my research team. I tried to make sure that the research designs are perfect, etc., etc. But the more the group grew, the more I withdraw from controlling what is happening and leaving it to the group. And what happens is a very nice thing, actually, when there's more and more problems because the group is bigger, but the solutions come from the group and not from me as a head of department. So the group is creating its own empowerment, its own management, its own solution-driven approaches. So, and that, I think, we underestimate the power of society. And the last thing I want to do, because I do not want to monopolize here, Agnes, the last thing, we just need to keep remembering that our welfare states in Western Europe, especially in the north of Europe, but also in Central Europe and even south of Europe, is a product of societal development. It was not a product of professional services. It is the society who created a welfare state, and then we added to that all kinds of professional services to just remain the welfare to keep on. So it is really the society evolutions, even societal revolutions, who created the welfare state. So the dynamics of society can be very powerful. And we have seen that in the whole revolution on health, on health promotion, on prevention, healthcare, etc. So I think it is very powerful that we accept that complexity as an intrinsic value in our research, the complexity of the community. And I'm a strong believer that solutions will come from the community. I'm stopping here, Agnes.
Thank you, Luc. It's nice that I also wrote down complexity is a value in itself, is something really worthwhile to consider and to reflect upon. Perhaps, Stephen, you can make a start by responding to the previous comments.
Yes, thank you, Carol. Thank you, Luc. Well, first of all, the comment from Carol on that you could also provide for a classification based on a continuum of control, I fully agree with. And I think Luc also touched on that when he mentioned the parallel with the research group and how it grew, and that letting go, things happen in the society by themselves. And it made me reflect on that if we want to understand something completely, and I think capture is maybe a bad term as Carol suggested, but understanding leans closely towards that curiosity. If we want to understand society, we sometimes have to as researchers resist the urge to remove it from its context in order to control it, because then what evidence do you have? You have it completely removed from its habitat, from its natural environment. To understand, we have to study society in its whole, in its natural environment. And that is a challenge, because as researchers, we want to control every variable. We want to make sure that what we find is relevant, is significant, but yeah, if you then reach to the other end of the spectrum where you have taken it completely out of its environment and have controlled for everything, then what you're measuring or what you're finding or what you're exploring, is it really still, can you still say anything meaningful about it when all relevant factors have been eliminated? So it's an ongoing struggle with every researcher, I think, has to grapple with for themselves. And I think especially in public health palliative care and as well as in sociology, that's a very relevant struggle, I think.
Okay, thank you. Carol? You muted, Carol.
Yeah, I know my mute tab got stuck, so I couldn't unstick it. I just thank you, Stephen. Also, I just also want to point something out, because the discussion so far and maybe Joseph's presentation has sounded like there's one research paradigm that we all share. And I just want to point out that I don't think that's the case, but we come from a wide variety of different research paradigms with different assumptions. And I mean, I have a clinical background, but I also have a background in anthropology and ethnography, both before and after that, during my doctoral studies, which means that I wasn't really schooled in the assumption of control, of researcher control, but more of curiosity as the driving factor. So I think it's important to try and both recognize that there is a diversity of scientific assumptions working within public health and palliative care, and that try and find ways of using these different assumptions together to puzzle together a broader repertoire of methods and approaches and research questions than each one of us individually has.
Thank you, Carol. I would like to address one of the questions that's in the Q&A section, and that, let me see, asks, is cross-setting comparison possible in palliative care, considering the cultural differences and economic and other barriers that differ between settings? Can someone of the panel members comment on that? Is setting comparison an option? Luc?
Well, I don't know what the real question beyond this question is. So that's not very clear to me. Of course, in theory, I would say it is possible to do that. The question is, what's the purpose of doing it? Mm-hmm. So what is the purpose of comparing two healthcare settings? So if it's just curiosity, it's okay. I think a lot of agencies, governmental agencies, are trying to implement quality indicators, and very often that is a kind of subtle control system from the government onto the services. So I don't know what the purpose would be for comparing different settings, because that means, as I understand the question rightly, comparing different health services. So more importantly, in public health, palliative care is not starting from a model of services, but starting from a population-wide approach. And I mean, I think Joe in his chapter also has somewhere a very nice statement about the failure of, I don't know where I can find it in his chapter, about palliative care. So palliative care is a wonderful solution, but it's for a limited number of people in a society. So it's a perfect, fantastic solution for the happy few. And so we forgot about that. And so the whole approach of public health palliative care should start from populations and look at what are the needs for the populations, and whether we can assess those needs and whether we can address those needs. That's the essential question from a public health palliative care perspective. And then, of course, you will have completely different research designs in order to compare. Then retrospectively, you can always compare different services if the data are in your database.
I think the question about comparing settings was inspired by a comment from during Stephen's presentation, where you cited one or more studies about comparing settings. So perhaps you can speak a little bit to that question.
I think the question is, can you meaningfully compare settings? And then it does relate to what you've said as well, is what the purpose behind it is. I think it depends on how much you pin down ahead of time, or you define ahead of time, or how your assumptions as a researcher or your discipline color what you're comparing and what you're measuring and what assumptions you have about what should be comparable. I think because the comment or the question mentions cultural differences, economic differences, different assets in different areas, availability, and several barriers. And I think if you can define a broad, and that's why I use death literacy as an example in my presentation as well, because it overlooks the idiosyncrasies of individual interventions. It's of course also limited and hasn't been validated across very many different cultures. But if you can find a common goal for, it depends on what you're studying, but for an intervention, you can compare that goal despite the idiosyncrasies in how operationalization and what the different objects and activities and components of your intervention look like. If you can show whether both of these and to what extent both of these interventions build a capacity for end-of-life care and support in a community, that's comparative. Of course, cultural differences can be huge in what people consider relevant at the end of life and how their quality of life is determined. For example, in certain religious groups, adherence to religious law may become very strict as they get closer to the end of life, simply because it suddenly becomes more relevant, while they may not have been very devout in life. So it's things like that. I remember an example as well when I once visited St. Joseph's Hospice, where they were puzzled why Muslim community in that area did not make use of their services, of the hospice services. And it turns out no one was talking about it. And only when they consulted with an imam did they find out that it was because there was a lack of running water to clean themselves. So there was water being provided, it just wasn't running water. And that was really relevant. So you have to kind of see what the relevant aspects are you need to compare. But I think comparison is always possible. You just need to be careful in making sure or doing your best to ensure that it is a meaningful comparison. And it all falls or stands with what the purpose behind the comparison is. So I agree with Luke's comment about what is the question behind the question. But yes, the short answer is yes, it's possible.
Yeah, and perhaps again, comparison raises in the end more question than it answers. So in that sense, it's a real scientific enterprise. Carol, you would like to comment?
Yeah, I just wanted to give an example of a comparative study that we did between the UK, Belgium, and Sweden, where we've had a lot of discussions about palliative services interaction with the community. And we did the same survey across all three countries about interaction using Libby Salno and Sally Paul's scheme of involvement with community to look at it. And I think what that did was move us from thinking that one place was better than the other, but giving us the possibility of understanding why and what kind of interaction there was with the community. One of the things that we noted was how driven it was by economics. That in the UK, for example, most of the hospices and palliative care facilities were totally dependent on donations. So of course they had to have an interaction with the public, whereas in Sweden, there was no dependence, virtually none, maybe 2%, something like that, on donations. So that there really wasn't a driving need, and they thought that this was beyond their mandate for what they were supposed to do. So I think that in some senses, it can get us away from this thinking about better and worse, and that we all should be doing the same thing, but understanding how to take cultural differences and economics and assets and availability into consideration instead. I also want to point out that there is a whole branch of meta-analysis that uses qualitative data to learn from each other. So I think that it really is important to learn from each other and to find systematic ways of learning from each other, as opposed to comparing better or worse and standardizing.
Thank you, Carol. There is one final question in the Q&A that's about the difference between hospice care, end-of-life care, and palliative care. It's not a very specific question, but I don't know if any one of you would like to comment on that remark.
My initial reaction is to defer to my senior colleagues here, but I can maybe offer my perspective on. I think in general, end-of-life care is more the overarching term for all care that relates to end-of-life situations, serious illness. Hospice care, to my knowledge, has always been more about people in the terminal stage or with a terminal condition that are closer to the end of life. And then there's, of course, terminal care, which is the last days or week. And palliative care is for all serious illness conditions or chronic conditions that at the same time you can still have curative care options available and being utilized. And it's focused more on the holistic approach to quality of life and well-being, which takes into account the social, psychological, physical, and spiritual aspects, but is started ideally. I mean, practice is often differs from this, but ideally together with diagnoses of a serious illness or chronic condition.
Mm-hmm. Luc?
Yeah, I think, again, why are you using these different terms? Huh? And I think we have to be very careful, because the term of hospice care was developed in the United States and in the UK, and it has a different meaning there than it has in Europe, hospice care and palliative care. So what we call in Europe palliative care has two concepts in America. It's hospice care, which is more the terminal care, and then what we call early palliative care is palliative care in America. So it is rather confusing, I think, when we are on an international scale to discuss these concepts. And I think it's also confusing for the patients. It's very, very confusing for everyone in society. And I think one of the fundamentals inside, at least in my mind for the last couple of years, is that we need to redefine what palliative care is. And also we need to discuss the use of those terms or the non-use of those terms. When it all comes to person-centered care. It all comes to goal-oriented care. So sometimes when I'm doing research in the hospital, you have a lot of barriers just due to the use of those different terms. For example, if you speak to physiotherapist or nutritionist, etc., they have all different. They give all different meanings to palliative care, and so they have a completely different patients on their minds when we speak. So most clinicians, even in Belgium, when you speak about palliative care, they only think about a terminally ill patient. They only think about a patient who's going to die within a week or something, or maybe 2 weeks, and so on. So we have in the academic work, we have a completely sophisticated terminology, but that doesn't respond to society, that doesn't respond to patients, that doesn't respond to health services, that doesn't respond to policymakers. So we really have to reflect more deeply about the consequences of those terms, not just for our societal purposes or clinical purposes or whatsoever, but also for our own research purposes, I think.
Mm-hmm. Okay, thank you, Luc, for this comment. I think we are at the end of this webinar right now. We have 1 or 2 minutes left. Thank you very much to all the speakers and the panelists for this interesting discussion. One thing I got from this is that, well, as always, research is more about questions than about answers, and that it's about finding balance on the one hand to categorizing, ordering, disentangling complexity, and on the other hand to embrace complexity and to have an open eye for the fluidity of many of the concepts and outcomes we are studying. So, well, hopefully this webinar inspires you to further work with these concepts and issues in your own environment. And I would like, at the end of this webinar, to attract your attention to a few of the other activities of the reference group. The first one is the 3rd International Research Seminar that is organized in Belfast, Northern Ireland, the 16th and 17th of November this year. And then next year we have the 8th conference of Public Health Palliative Care International in October in Bern, Switzerland, and associated with that, preceding this conference, is the Public Health Palliative Care Academy, a summer school, which is on the next slide, 18 to 20 October, which is also organized in Bern and where you can participate as a student. So very welcome to apply for participating in this academy. The final slide, I think, is a QR code where you can find the newsletter of the reference group. You are very welcome to sign up so that you can be updated on activities of the group on a regular basis. Thank you very much, and hope to see you at one of the next activities. Luc, would you like to add something?
No, perfectly chaired webinar, Agnes. Very much thank you for your competent chairing of this webinar.
Okay, thank you. Thank you all, and see you soon, hopefully.